So we're going to go ahead and get started. My name is Elizabeth Aloni, and I'm with Schneps Media. Schneps Media is the largest local media outlet with over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, and Philadelphia. Today, we're thrilled to bring to you Prostate Cancer Awareness webinar, Early Detection Saves Lives. And we have with us some illustrious guests that we are thrilled to have join us. I want to tell you a little bit about each of them. First, I'd like to introduce Dr. Erroll Mallett. Dr. Mallett is a skilled and experienced urologist. He caters to the locals of New York City. Dr. Mallett is the medical director for Vantage Medical Group Urology Division. He focuses on giving patients the highest quality of care while guaranteeing their participation in managing their own medical condition. He has a special interest in prostate, bladder, and kidney cancer and minimally invasive approaches to treating them. Dr. Mallett attended medical school at the University of Connecticut. He then went on to complete a residency in urology at Montefiore Medical Center, Moses Division Hospital. To advance his clinical skills, he finished his fellowship training at Montefiore Medical Hospital. He also holds active membership in the American Urological Association and American College of Surgeons. Welcome, Dr. Mallett. So happy to have you here with us.
Thank you so much. It's really a privilege and an honor to participate in this worthwhile program. Thank you so much.
Thank you so much. Next, I'd like to introduce Dr. Paul Gliedman. Dr. Paul Gliedman currently serves as the medical director of Vantage Medical Group Division of Radiation Oncology. In addition, he serves as director of the Department of Radiation Oncology at Mount Sinai, Brooklyn. Dr. Gliedman has over 25 years of experience in managing cancers of the breast, prostate, lung, central nervous system, gastrointestinal tract, as well as gynecologic cancers. He utilizes cutting-edge treatment techniques such as intensity modulated radiation therapy, rapid arc, prostate brachytherapy, and PET-MRI scan-assisted delineation of tumor volumes. He's implemented exceptional localization techniques for the treatment of prostate malignancies using implanted fiducial markers, resulting in greater tumor control and reduced morbidity. Dr. Gliedman also perfected a novel decubitous, he'll tell me that about if I'm saying it right, positioning technique for breast cancers, which allows for superior heart and skin sparing. In addition, he's one of the leading experts in the treatment of brain cancers using cranial stereotatic radiosurgery, as well as body stereotatic radiosurgery for lung, bone, and liver tumors. His previous leadership positions have included Director of Radiation Oncology at St. Luke's Roosevelt Hospital Center, New York, where he served as a principal instructor in the Stereotactic Radiosurgery Fellowship, and Director of Radiation Oncology at Hackensack University Medical Center, New Jersey. Welcome, Dr. Gliedman.
Thank you, Elizabeth. Thank you for that kind introduction.
My pleasure. We're honored to have you here. And I would also like to introduce our last panelist, Ed Randall. For more than 4 decades, Ed Randall has been a familiar voice and a mainstay on the airwaves, becoming synonymous with baseball and one of New York's greatest sports entertainment exports. Rising to fame in the 1980s with his hit show, Talking Baseball, Randall recorded 500 half-hour television shows with what he describes as the greatest baseball legends you can imagine, ranging from Mickey Mantle to Ted Williams to Yogi Berra to Cal Ripken and even Hollywood star and noted Chicago Cubs fan, Bill Murray. Randall was faced with the unimaginable as he was diagnosed with prostate cancer. And with his diagnosis and later his recovery, a vow was made. In 2003, Randall founded Fans for the Cure, a nonprofit organization that helps men recognize the risks of prostate cancer while broadcasting the importance of early detection to both extend and save lives. When caught early, the survival rate of prostate cancer is nearly 100%. Welcome, Ed.
Elizabeth, great to be with you and with the doctors. Thank you for having me.
Thank you. Thank you. This is such an important topic and so important for people to understand the importance of early detection. Dr. Mallett, why is prostate screening so important?
Thanks, Elizabeth. That's a very important question. Prostate cancer screening is super important. It's really the only true way to, number one, initiate the screening process and ultimately the diagnostic process. The diagnosis is the ultimate way to identify the issue, and prior to that, the screening mechanism is of utmost importance. I think it's very important for us to identify what's considered risk factors for prostate cancer. One is, and I think it's important to differentiate risk factors versus the diagnosis of prostate cancer, because not uncommonly those two issues are confused. An increased PSA represents a risk factor for prostate cancer. A family history of prostate cancer is another risk factor, a very important risk factor. An abnormal, what we call DRE, that is the prostate digital examination, constitutes another important risk factor. And another risk factor that's very, very important, which is often overlooked, is the doubling time, the change from 1 year to another of the PSA level. Even though you may have a PSA of maybe 2 or 3, if it doubles within a short space of time, it's equally important as an elevated PSA. Okay, so it's very important to identify, number one, the risk factors first of all, and then once the risk factors are identified, the diagnostic piece comes in place, which we'll get into a little bit later on in terms of a true diagnosis and then subsequent treatment. Why screen again? It's the only way that one can, number one, identify a problem as early as possible. And as we all know, early diagnosis and intervention saves lives.
Yes. Let me ask you this, because obviously the big elephant in the room is COVID. And people are concerned about COVID. What would you say to someone who said, well, I don't know if I should get screened because there's COVID, I'm afraid? You know, what would you say to them?
Very important question, Elizabeth. I think despite COVID, life goes on. And, you know, we're living in a very trying time right now. But despite that, we have to look forward to tomorrow. And my advice would be that you should not delay any significant diagnostic tool that's available to you, and especially as it relates to prostate, not only prostate cancer, but to cancers in general, and even other medical entities. One should move forward. You know, again, obeying all the rules that are in place to minimize exposure to COVID. But despite COVID, I think most physicians and people of influence around us will agree that we should not sit back and delay, but just to move forward with our lives and seek out the appropriate diagnostic tools that are available to us.
Because as you said, early detection is such a huge lifesaver, that not to use COVID as an excuse not to be screened, but rather take the precautions necessary and do it as safely as possible.
Correct.
That makes a lot of sense. Dr. Mallett, how often should men be screened, and at what age should they start?
Okay, the general recommendation is that around the age of 50, one should definitely consider screening. However, I think it's very important to break it down into the high risk category. For patients who are at high risk, again, families, history of prostate cancer, a known history of PSA elevation, one should certainly consider screening at an early age. Another important factor are patients who are of African-American origin, Afro-Caribbean origin. The screening age is certainly lowered, And my recommendation would be at age 40, that especially in the high-risk group, that screening should be initiated at an earlier age. And I would recommend age 40 as the initial age for screening, especially for the high-risk patient.
Okay. And how often should one be screened once they start screening?
Yeah, once the process is in place, yearly screening is recommended. A digital rectal examination, in other words, the prostate physical examination, the blood test, the PSA, should be done yearly, because within that year, there can be a lot of changes, a lot of important changes, which needs to be identified within that year, so that one can address those changes as early as possible.
So very important to begin screening either at age 50 or 40 if you are a high risk factor, and to really make sure that you're doing that every single year to make sure that you
Correct.
can be aware of any changes that occur.
Correct.
So tell us a little bit more about testing. What exactly is a DRE, and what should a patient expect?
Yeah, the DRE is an abbreviation for digital rectal examination, and I know it can be a bit uncomfortable, but it's a very brief examination through which the amount of information that can be gathered is tremendous. So the DRE, again, is the digital examination via the rectum, unfortunately, but it gives so much information, and it's such a quick examination that that it should be done. So the DRE, number one, in terms of physical examination. The second examination, again, is a blood test called the PSA, which stands for prostate specific antigen. It's a protein that the prostate secretes that gives you an idea of certain activities in the prostate. Prostate cancer is not the only entity that produces a high PSA, but it's certainly the most significant one. So the PSA determination, and along with the DRE, are the two initial basic tests that should be done. I think it's very important not to separate the DRE from the PSA. A lot of patients feel that, you know, I had a PSA done and it's normal, so everything's okay. Not exactly accurate, because one could be abnormal, the other one could be normal, and vice versa. So therefore, the recommendation is that you get not only a PSA but also the DRE together, and not separate or independent of each other.
Thank you for saying that. In fact, one of our attendees asked a very good question and asked, do you need a PSA and a DRE every year when you go for the test? And you're saying that you should do them together. Is that do it every year, both of them?
That, in terms of what constitutes the proper prostate cancer screening, the DRE, the digital rectal examination, and the PSA, that's what constitutes a proper examination. If you have a choice to do one or the other, it's better than nothing. But at the same time, the concurrent tests are very, very important, and one can be normal, the other could be abnormal, and you might inadvertently miss the diagnosis of prostate cancer just because you might not have done one or the other.
Is that something that a patient would discuss with their doctor and request? Or do most doctors say do both of them every year? Or as a patient looking out for their health, what do you recommend? Do you recommend that they do both every year and talk about that with their doctor?
No, the recommendation absolutely should be that both be done on a yearly basis. Too often I see patients coming in with a PSA done, and in their mind they've had prostate cancer screening or initially, but without a doubt the PSA can be normal and the DRE can be abnormal, and if one or the other is abnormal, then you have to move forward with the next step, which is diagnosis. And those are the two absolute indications for pursuing the diagnostic piece, which is a prostate biopsy, an abnormal DRE and or an abnormal PSA.
Great. Thank you so much for clarifying that. That's so very important.
You're welcome.
So tell us what constitutes a diagnosis and what needs to be addressed to fully confirm a diagnosis?
Correct, because that's a great question, and it's a question that many patients ask almost on a daily basis. We've heard of you've heard of the MRI, and the MRI is a great test, and it might shed a tremendous amount of light on prostate anatomy, but at the same time, it's not a diagnostic piece. The only diagnostic piece for prostate cancer is the actual prostate biopsy. That's the only way the condition can be diagnosed. You have to do a prostate biopsy. Without that, you really can't diagnose prostate cancer at all. And as I said, the MRI gives you additional information, which might be important in cases where there might be, equivocal situations where you might have a patient who've had a biopsy that was negative, but yet the PSA keeps rising. The MRI could be very helpful, but it's not diagnostic, and it really is an adjunct to the actual diagnostic process, which is the only way that one can diagnose prostate cancer.
Now, we have a question from the audience. Do you need to do an MRI before a biopsy, or what would be the process? So you go for the PSA, the DRE, one or both comes back abnormal. What's the next step?
The next step is a biopsy. Okay, the MRI can be. It's a test that's in vogue. It really gives you an additional. It can give you additional piece of information regarding the localization of the prostate cancer. So, my current thought is that if one can get an MRI prior to a biopsy, it can only enhance the diagnostic and biopsy procedure, because it can help you to guide your diagnostic areas to more precise localization of areas that are more likely to have prostate cancer than others. Because when you do the biopsy, you're taking usually a minimum of 12 samples, and you really can't biopsy the entire prostate. Otherwise, they can only do that from total removal. So if you want to increase your, the steps to which you can confirm the diagnosis, then the MRI absolutely is a good tool to add to your conventional prostate ultrasound guided needle biopsy. So if it's at all possible to have an MRI prior to, it's a recommendation, and but it should not be in place of a prostate biopsy.
Got it. Makes sense. Thank you so much. We're going to circle back to you in a little bit, because I know we have a lot of questions that people want to ask. Thank you so much for that information. Really so important, again, how critical it is to do the screening, make sure it's the DRE and PSA, do that on an annual basis, and how critical that is. Thank you so much, Dr. Mallett. Speaking of the importance of diagnosis, I think this is a wonderful time for us to turn to Ed. Ed Randall, who is here with us. Hello.
Hi.
Ed, tell me, how old were you when you were diagnosed with prostate cancer? And can you tell us a little bit about that discovery process? Or surprise process?
Well, it was surprising to me, I'll tell you that, Elizabeth. I was 47 years old, relatively young, they tell me. And No history of cancer in the family, no symptoms, of course, because prostate cancer in its earliest stages has no symptoms, as I came to find out. And I went for my routine annual physical. At least I thought it was going to be routine. And the next day, my doctor called me. My doctor had never called me. John Cornwall, just the great John Cornwall, a friend of Dr. Gliedman's. He was my GP, and he says, you know, your PSA is really high. Now, at this point in time, I'd been broadcasting for a number of years, and my only definition of PSA was repeat after me, public service announcement. I had no idea this was an indicia for cancer. And he said, well, your PSA is really high. He said, but you know, maybe the lab screwed up. Let's come back. Let's take another blood test. We'll send it to another lab, which was the last thing I wanted to hear because I've had a deathly fear of needles since the age of 5. But I thought under the circumstances, I better go. So I went. And the results of the second PSA were exactly those of the first. I was filled with cancer. But through God's grace, I got, and I'm a baseball guy, so I'm going to say it, I got a second at bat at life and came out the other side, thank God. On the day in which, so I was so fortunate to be with John Cornwall because he got me to the esteemed Dr. Nicholas Romas, world famous and chairman of the Urology department at Columbia Presbyterian, forgive me, at St. Luke's Roosevelt Hospital. And my oncologist was the great Dr. Paul Gliedman, who I love to this day. But on the day in which I was to be operated on, and I chose to have the implantation of radioactive seeds with consultation from Dr. Gliedman and Dr. Romas, that morning, a guy sat me down at 6 a.m. and he goes, you know, it's really good that that you've come in here. He said, because normally we don't screen for PSA. Doctors don't screen till the age, and the doctor just mentioned this, till the age of 50. Now I'm 47. And I said, well, you know, if we had waited around till 50, the only decision that my family would have had would have been open casket or closed casket. So I was so grateful for the dedication and the great work of my doctors, which got me my second at bat at life, as I like to say.
Thank God. Wow, unbelievable. So going through that process, I'm sure was life-changing. And I understand that you made a promise that you were going to do something getting through this. Tell us how then you went from that and dealing with your cancer to starting your organization.
I was when I came out the other side, I just I have a friendship with a guy who played for the Yankees, and he played for the Texas Rangers, Cleveland Indians. A guy named John Ellis, and he had leukemia and had leukemia in his family. And he would go down to Sloan Kettering. He lives in New London, Connecticut, and he would go down to Sloan Kettering, and he wouldn't see the same people every week. And it wasn't so much that those people had passed away, it was they didn't have the financial wherewithal to continue seeing the doctor. And John said to me memorably, I wrote a book, and he's in this book that I wrote, and he said, I made a promise to whoever you make a promise to, that if I survived my cancer, I would do something for others. And he founded this Connecticut Sports Foundation, which is phenomenally successful. When I got out on the other side, I said, you know, this is crazy. I said, I had no symptoms, and there's an almost 99% cure rate of prostate cancer if it's detected early. I said, there's got to be tens, hundreds, thousands, millions of guys like me walking around feeling fine, thinking they were fine, when in fact they're time bombs because they haven't gone to the doctors. We got to get to those guys. So I founded my charity, my 501c3 Fans for the Cure, dedicated to the proposition of spreading the twin gospels of prostate cancer awareness and the life-saving value of early detection.
Incredible, incredible. Tell us a little bit about what you've done with your organization and how you've, what your key messages as the ambassador to men you've become.
Well, first of all, I have a tremendous stage because I'm on the air in New York. And I'm on the air in New York on the most popular all sports talk radio station in the country, WFAN. It was the first station in the country to adopt an all sports talk format. So I stop my show every single week on the air to talk about the importance of going to the doctors. Let's just boil it down to that, because that demographic that listens to Ed Randall's Talking Baseball is the demographic that is most susceptible to prostate cancer. So there's that element of being on the air, and and don't even think about stopping me from doing that, because I'm going to do it no matter what. Um, the other aspect of what we have done, we do prostate cancer free screenings, we do seminars, and I spent 7 years in minor league baseball broadcasting, and have had a lot of relationships with league presidents in the minor leagues or owner operators of minor league franchises. And back in 2007, I said, my God, there's 40 million people that go to minor league baseball games every season. That's exceeded only by Major League Baseball. There's more people that go watch minor league baseball than watch the NFL in person, or the NBA, or the NHL. I said,
Wow.
what a great opportunity that is. So we started our baseball road trip in 2007, and through 2019, because there was no season this year, we were in more than 1,200 ballparks with local volunteers working our tables, handing out our life-saving material. And I'm eternally grateful to all these organizations from coast to coast. There's minor league baseball in 39 states that open their doors to Fans for the Cure.
How fantastic. Wonderful. I can only imagine the number of lives that were saved with this education. What is your website if people want to go and learn more about your organization?
Well, I appreciate the opportunity, Elizabeth, to mention that we are at fansforthecure.org, fansforthecure.org. And we have a men's support group that we started recently. We're moving around the edges here of our lives being redefined by going on Zoom and doing virtual events. So every second Thursday night, which includes tonight at 7 o'clock Eastern Time, we will gather a group of men who have either gone through prostate cancer or have had prostate issues. And I can tell you that in a very short period of time, the response has been phenomenal, with gratitude that these guys have come to us, have found a place to talk about it. Well, this happened to me while I was convalescing. And another guy will go, you know what? That's crazy. I thought I was the only guy who had that happen to me. So it's been great. Uh, Women like yourselves, Elizabeth, are the superior species. And I'm not trying to pander, but it's the truth. You go to the doctors like you like it or something, but you go. And men, it's, I don't know, it's in their DNA that they don't go. Well, I feel fine. Well, I felt fine on the day that I was diagnosed with cancer. And Dr. Gliedman will tell you I was full of cancer. So, we are doing a lot of really good events, and we welcome everybody. We're at fansforthecure.org. If anybody has a question, we're happy to help them. We have a medical advisory board of which Dr. Gliedman, I'm proud to say, is a member of. We have 36 of the greatest cancer doctors in this country, and we are constantly doing referrals for anybody who may need one.
Fantastic. Such fantastic work. Thank you so much. And I did put the website in the chat for everybody to be able to access. So important for people to be able to have resources and be able to have other people who understand one another. You're right. Women tend to create support groups for about everything, but it's really nice to see a support group for men where they can support one another going through this and coming out the other side. So thank you so much, Ed. And obviously so important giving people support and making sure people go and get tested and screened and making sure that people are supported. But, now I really would love to turn to talking about the treatment of prostate cancer. And so turn to the tremendous expert, Dr. Paul Gliedman. Dr. Gliedman, what are the treatment options for prostate cancer?
Okay. Well, first off, before we say what the treatment options are, it's important to remember what both Dr. Mallett and Ed just went over. The earlier, the better. Not only that, the earlier, the better in terms of curing it, but then when you get to someone like me, you have options. If you're found really early, there's many options, from not getting not getting treatment right now, active surveillance. Maybe we're just going to watch it and monitor it, to having the prostate removed with surgery. There's radiation therapy options, both external radiation with what's called IMRT, which is given over a period of several weeks, or what's called CyberKnife or SBRT treatment now, which is just 5 treatments, or putting seeds in the prostate or brachytherapy. But again, having all those options, my favorite consultation is a patient who comes to me so early that I can go through each one of those. If a patient comes to me in a late stage disease, we're not talking about we're just going to watch this. We may be beyond the point where we can do it in just 5 convenient treatments. We may be talking about much more aggressive treatment that needs to start soon. And this is basically, you have very limited options. So the options I just mentioned, from active surveillance, surgery, radiation, are open to men who are diagnosed early. So again, that's the important reason to diagnose it early.
Very, very important message. Thank you for that. And what is the prognosis for prostate cancer patients?
Well, thankfully, the mortality from prostate cancer has dropped dramatically just over the last 20 years, from earlier diagnosis to better treatment options. Most men diagnosed with prostate cancer are diagnosed with what we call local or local regional disease, meaning it hasn't spread in the body, it hasn't spread to bones or elsewhere in the body. And these men are highly curable, nearly, we can't say 100%, but nearly 100% of the time.
Mm-hmm.
Unfortunately, in a minority of times, we still see men, as Dr. Mallett can tell you, who are diagnosed with advanced prostate cancer, who walk around, like Ed said, unaware that their PSA is elevated, unaware that they have cancer, and only come to the doctor maybe when they have an ache or a pain, or the cancer has spread to the bones, in which case the 5-year survival may only be 30%. So you can see it's 2 entirely different worlds. We don't like to go to doctors. Ed is right. Men are just different species. But if you do it and you get diagnosed early, it doesn't mean you have to necessarily do treatment. Hopefully it'll be so early that you can talk about maybe monitoring your cancer and treating it when maybe you're psychologically ready to do that, or your doctor feels it's important to do that. But you want to have all those options. Having options, although, like I say to patients, I know this is confusing and we'll go over it several times, you want to have options.
Yeah.
You want to be faced with a lot of information and have a lot of avenues open to you, and think about it, get other opinions, see different specialists, and take your time doing it. You don't want to be in a situation where either there's very limited options and this is what you need to do now to hopefully survive, or we no longer can cure you, we're just going to treat you and you're looking at a very limited lifespan. So I mean, these are 2 different worlds, and Ed is such a great ambassador and he's so enthusiastic and passionate. If there were more Eds around, we could get the message out, and hopefully there'd be men diagnosed early and when they have all these options available.
Such an important thing. Time is really the difference between life and death. And if there was ever a thing to motivate a man to go to the doctor, I certainly hope it would be that. And certainly talking about it here, and we'll share the recording of this as well to as many people as possible, because it's just so important for people to know. Dr. Gliedman, you mentioned watchful waiting and active surveillance. Can you tell me the difference between these and a little bit about that?
Well, we tend to, I'm glad you brought that up, because it is confusing even to us physicians. The terms tend to be used interchangeably. Watchful waiting was a term we used in the beginning, maybe several decades ago, but really active surveillance is a much better term in what we do now. Active surveillance means someone like Dr. Mallett finds your prostate cancer. It's a very low volume disease, low PSA, low grade cancer. And in consultation with your doctor, you decide, I see the options, like I just mentioned, surgery, radiation, various forms. You're telling me right now it's not immediately life-threatening. I have time, and maybe I don't want to go through that treatment right now. I want to just monitor things. And that can be important for young men who maybe want to avoid some of the potential side effects of treatment. And more importantly, for an older man who maybe his prostate cancer was found early and is growing so slowly that it may never require treatment. So active surveillance means in conjunction with your urologist, with your doctor, you decide to watch it, but it's active, meaning you go for checkups, you get your PSA monitored, you very possibly will get MRIs and likely get repeat biopsies. So it's not like putting your head in the sand. It's actually very, very active, and you need to be motivated and follow up with your urologist. And then at a certain time, if there's signs that the cancer might be progressing or getting more serious, either by the PSA or the biopsy, then you can revisit your treatment options. Watchful waiting is a term we don't really use too much nowadays, but what it really means is you have a patient who either is very, very ill for another reason, maybe has very, very bad heart disease, is very old, elderly, in poor health with a limited lifespan, but someone does a blood test or a biopsy, finds prostate cancer, but they have so many other medical issues, we're not even going to address prostate cancer right now. We might just monitor it, but we're not going to talk about aggressive surveillance or aggressive treatment because it just wouldn't make sense.
So it really is dependent upon the patient. Again, another reason why it's so very important to go to the doctor to obviously determine whether or not you have cancer and be able to get specific information that's right for you. Thank you so much. We have a bunch of questions from our attendees who are eager to ask them. So one of our questions that was asked was, can men still father children after a diagnosis? Who wants to take that? Dr. Mallett, Dr. Gliedman? I mean, maybe it's after a diagnosis and then also after treatment, because I think another question too that came up was, what are the side effects of cancer treatment, of prostate cancer treatment?
Yeah, that's Dr. Mallett here, the urologist. No, a very important question, which we encounter almost on a daily basis. Yeah, again, it's all about early diagnosis, again, given and the ability to have all the options available to you. And as Dr. Gliedman so eloquently pointed out, it's very, very important that the options are available to you, because with the options you can do a lot more. In terms of the ability to have children, and I think Dr. Gliedman alluded to it a little bit, in the sense that under the watchful waiting umbrella, so to speak, then one will have the ability to plan, because as he also mentioned, there are side effects to different treatment modalities, and with those side effects, infertility or the inability to have children is a potential side effect issue. So with, again, early detection, early diagnosis, the options again are available to you. I can't emphasize that more, anymore. It's so important to have all the options. And one of the options that will be available to you is the ability to have children. And there's another potential option that one can engage in at the right time is a situation called sperm banking, where you can actually, bank your sperms in preparation for conception later on. But again, it's all about early detection and with all the options that are available to you. But the answer is yes, that you can have the ability to have children. But again, you have to look at the different options that are available to you and exercise those options within the realm of longevity and what your goals are at the time of diagnosis.
Thank you. Again, time, making sure that you find this as early as possible. Ed, we have a question for you. Someone wants to know, can people reach out to your organization if they can't afford testing? Do you help them find avenues for that? Is that something they should reach out to your organization about?
Without a doubt. Yes, please.
Okay, wonderful. And another question for you too, Ed, and it's probably Dr. Gliedman and Ed also. Someone asked that of all possible treatments that, Ed, you said that you went into choosing seeds over all the other choices. And they want to know if there's a reason for that. Maybe you and Dr. Gliedman can kind of give us, obviously your situation is yours in particular, but perhaps there's something that you can share with our attendees.
Well, I'll tell you this, and then Dr. Gliedman can take it from here. I'll be brief. At the time of my diagnosis, there were really only two possible therapies. First was having the radical prostatectomy, having it out, or this new process back when I was diagnosed, relatively new at that time, the implantation of radioactive seeds. And I chose, with the consultation from Dr. Romas and Dr. Gliedman, to have the seeds, with the proviso that if the seeds didn't work and did not eat the cancer, I can always come back and you can always take the whole thing out. But excuse me, but fortunately it worked, and Dr. Gliedman can talk some more about it.
Thank you, Ed. Dr. Gliedman, would you like to share a little bit more about that?
Well, yes, again, there are many treatment options, and it depends on how early you're diagnosed and your particular stage of cancer when you're diagnosed. In general, like Ed just said, the main options are surgery or various forms of radiation. Not all those forms of radiation are available to all men. Those options of radiation, depending upon their diagnosis. Again, the earliest diagnosis, all options are available. Later your diagnosis, still options, but less options. For Ed at the time, things like the external radiation has gotten better, more technologically advanced. At that point in time, like he said, it was either a seed implant combined with radiation or having the surgical removal. Those were the best options at that time.
Great, thank you. Again, early diagnosis.
I'd just like to
Yes.
hear and just applaud the medical community and all the researchers who have now come up with all these other therapies that the doctors have spoken about since the time of my diagnosis. The progress in that world has been enormous.
Yeah, good to that point, because one of our attendees asked, CyberKnife is being widely advertised. Can you speak, Dr. Gliedman, more about this treatment and technology?
Right. So I briefly alluded to it in my treatment options for men who are diagnosed at an early stage. CyberKnife, or another word for it is SBRT, or stereotactic treatment, is when instead of giving a course of external radiation daily, Monday through Friday, for 8 or 9 weeks, we give just 5 treatments. That is a very promising way of doing the treatment. At this point in time, we're mainly using it on men who are at the earliest stages, because those are the men who seem to do the best and we have the most information on it.
Terrific, thank you. Dr. Mallett, one of our attendees said, isn't it true that every man, if he lives long enough, will develop prostate cancer? Is that true?
Well, it's a very true statement. If you look at most men who are 80 years old or older, there's a good chance that 80% or more will have prostate cancer. And prostate cancer develops with advancing age. There's no question about that. So by the time you're in your 80s or 90s, there's a very, very good chance that you'll have prostate cancer. The good thing is that you may have it, but you may not even be aware of it. Okay, so it's a relatively true statement, but again, it's not 100% of men will have prostate cancer, as they get into their late 80s or 90s, but a very high percentage will have prostate cancer. And there lies one of the good things about prostate cancer, is that most men will actually live with prostate cancer and not die from it.
That is good news, but not news to me not to get checked. You
Correct.
Still have to get checked every year. Another question, this would be for you, Dr. Mallett. Is there genetic testing for prostate cancer like there is with breast cancer?
Okay, that's a very good question. There are a lot of genetic testings that are available to enhance the the recommendations for a patient to look further. Okay, but I just want to make an amazing point in the sense that you can't replace genetic testing with diagnosis. It's just like with the MRI. It's a very good tool to sort out, where a patient may be in terms of their genetics and their predisposition to prostate cancer or other cancers. Again, a very, very important tool, but it cannot be used in place of the early screening, mechanism and the diagnostic tools that's available to truly diagnose prostate cancer. They're very good tools to guide you, but it's that's as far as any kind of definitive diagnosis or therapy, it has its limitations there. But on a whole, they play an important role in cancers in general, and familial tendencies and the way to recommend certain things to different patients based on their genetics. Very, very important, and a very good and a very important question that was asked.
Terrific. Thank you so much, Dr. Mallett. I have a question for Ed. Someone is asking, how long after treatment did you return to normal activity? And did you have any side effects, if you don't mind sharing?
No, not at all. First things first. I was in I was operated on by Dr. Romas on March the 8th. You always remember those dates, Elizabeth. You remember the days you're diagnosed. You remember I was diagnosed on November 8th. So it was December, January, February, March, 4 months to the day I was operated on. 1 week later, I was in spring training. And I started a tour of spring training camps. And I was in Yankee spring training camp. And Joe Torre was still the manager of the Yankees. And he had been a prostate cancer survivor. And I remember leaning on the batting cage during batting practice and saying to him, "Boy, I said, you won't believe what happened to me since the last time I saw you." And so I told him, and we talked about that. So that was 1 week. As far as side effects are concerned, and it's really something, Elizabeth, that you bring that up, because when we have our med support group, as we will tonight at 7 o'clock Eastern time, to hear all of the horrific side effects that these poor guys have gone through. And I tell the story all the time that on Tuesdays at 3 o'clock, it was time to go into the bowels of St. Luke's Roosevelt Hospital, go visit my dear friend, Dr. Paul Gliedman. And he would ask me, do you have this? Do you have this? Do you have this? And every week I would say, to paraphrase Lou Gehrig, I consider myself the luckiest, I said another word, I consider myself the luckiest guy on the face of the earth. And because none of that happened. And I'm just lucky. I didn't ask why it happened, why it didn't happen. But my God, I hear about it now every second Thursday night when we do our prostate cancer support groups. And I'm just a really lucky guy that I got through it without any major side effects.
That's wonderful. Thank you so much for sharing that. Dr. Gliedman, we have a couple questions for you. One is, where do I turn for guidance in choosing the right prostate cancer treatment for me? This gentleman said he's spoken to a surgeon about who's advocating robotic prostatectomy. Am I saying that right? And a radiation oncologist advocating MRI guided stereotactic radiation and hormone therapy. How does one choose? And obviously we're not asking you to tell him what to do, but there's this, I'm sure many men go through that, this feeling unsure.
Right. I mean, this is the other side of having options. Remember I said it's good to have options, but yes, it can be confusing. It sounds like he did exactly the right thing. He got opinions from different physicians, both surgeons and radiation oncologists. Listened to both very carefully. For most men, this is what I tell my patients, and again, without knowing the particulars, most men, they have either option. I mean, I'm not going to say, well, radiation is better, it has a higher cure rate, or surgery is better. You can't really say that. Men have to be comfortable both with the option they choose and with the physician who's going to do it. So it sounds like he's gotten 2 opinions, maybe get a 3rd opinion. And at the end of the day, once if you have physicians that are telling you can do either one and you still don't know which one, go with your gut. You have to be comfortable in what feels right to you.
Thank you. Someone also asked, is there chemo, you haven't mentioned chemo, involved in treatment for prostate cancer?
Not so much. We use what's called hormonal therapy and various forms of hormonal therapy. Thankfully, chemotherapy is only reserved for a minority of men who are in very, very advanced stages and have failed other treatments. So it's used, but not commonly for most men.
Thank you.
Elizabeth, if I may add,
Please. Please do.
I just wanted to re-emphasize what Dr. Gliedman had mentioned in terms of the decision that the patient has to go through. It can be very confusing even among physicians, and it's so important that the patient take advantage of all the different options that are available and the different opinions and the different experts, because every patient is different. Every single one is different. And I think it's important for each patient to have all the information that's available to them: surgical, radiation, watchful, hormonal treatment, and and have an educated option that's available, and to make a decision that's a lifelong decision. And I think it's very important for them to seek out the different expertise that are available and come up with their own conclusion along with the guidance of their physician. Very, very important. And again, the earlier you're diagnosed, the more options you have available, and the most likely a better outcome.
Thank you so much for that. I could sit and talk all afternoon because this is such incredibly important information, but I want to be respectful of all of your time. And so I'd love to just wrap up by asking each of you, what would be your tip that you would give to, a relative, a close family member around prostate cancer? Do you want to take that first, Ed?
Sure. I go up to guys and say to them, "Hey, when was the last time you went to the doctors?" I mean, these guys should punch me in the head. They should slap me for asking that question. But it's really important to me because we believe in no empty chairs, Elizabeth, on Thanksgiving. Okay, and there's an almost 99% cure rate of prostate cancer is detected early, and I'm one of those lucky guys. So it's important to put it on the table and say to the men, when was the last time you went to the doctors? You need to do this. It's important. It's especially important in the African American community because the incidence of prostate cancer is 2 to 3 times higher than it is in the white community. It's horrible what's going on there. And we've done a lot of work in the Black community, in churches and such. So it's very important to tell men that we want them to have good outcomes, as the doctor just mentioned, and that and there are organizations such as ours at Fans for the Cure that are there for them 24/7. I have no off switch. So whatever I can do, I'm happy to do it. I believe there's some mystical reason why I was allowed to go to the other side and get a second at bat at life. That was when my life began. There's a reason, I think, why the big cleanup hitter in the sky kept me around. And I've toured spring training camps, a lot of them. And I've said to the players, I'm the only CEO you're ever going to meet who hopes to go out of business. That time you guys get off the field today, I hope there'll be a cure for prostate cancer. Until that time, I will be the car alarm you can't turn off. To tell the men in your family that they are loved and they are wanted and they are needed and they are cherished and they have a responsibility to go to the doctors.
I love it. I love it. Thank you so much. Dr. Gliedman, that's a tough one to follow.
I was going to say, who can say it better than Ed?
Yeah.
Don't put your head in the sand. Get tested, go to your doctor, have treatment options if you need it.
Wonderful. Dr. Mallett? Oh, you're muted.
The diagnostic process, after it's done, most patients will tell you it wasn't as bad as I thought it was. So I think it's very important. A message that should be sent out is that whatever the issues are with not going to the doctors, once you go, it's you know, you'll never regret it. And in most cases, patients, you know, they're so thankful that they were encouraged to go, and that's my drive home point. And that, you know your risk factor. African Americans, patients with family history, they should be even more diligent in seeking out you know, that diagnostic piece, because at high risk, things can happen quickly. And as Ed pointed out, you know, that whole traditional screening age at 50 is only a guideline, and that age 40 is maybe a little bit of a stretch on the early side, but their patients were diagnosed earlier than age 40. So, you know, it's very important for you to make a decision to get screened as early as you comfortably possibly can, and go for it.
Thank you so much. I think all of you were really so helpful in driving home the point that it is so important to take care of your health and see your doctor and get your annual tests. Men, we love you. We want you around. So take good care of yourselves. Thank you, Dr. Mallett, Dr. Gliedman, Ed. Thank you so much for being here with us today, for educating us, driving home the point of how important it is to get tested, get detection early. And I'll keep saying it over and over again. We will have a recording of this webinar that will be available on the Schneps Media YouTube channel, so you can see it again. And please share it with the men in your life. You know, any friends, family, share this with everybody, and be the alarm that can't be turned off. Like Ed said, take care of yourself and your friends. Thank you all for being with us today. Thank you so much to our incredible panelists. I want to thank our attendees for spending some of your afternoon with us, and I want you all to stay safe, stay healthy, and look forward to seeing you on a next webinar. Have a wonderful afternoon. Bye-bye.
Thank you very much.